Good evening and welcome. My name is Michael Flynn. I'm a fertility doctor on the Gold Coast. I'm part of the Queensland Fertility group, and I welcome you tonight to what I'm hoping is going to be a interesting session. It's a slightly unusual session for me because usually I just talk all things fertility, but I wanted to talk about some very special topics tonight. I know, and I'm hoping that there's people watching and listening from all over. And so even though everything I'm about to say has access to all of Queensland Fertility Group, and we have offices all throughout Queensland. So the comments I was going to talk about tonight was what genetic tests are available, not just with IVF, but to every single person, every single couple that wants to get pregnant. What's out there? Secondly, if there is any abnormality with genetics, what's available with IVF? Thirdly, what tests are available once we are pregnant? What can we make? Can we make a difference? And then finally, I want to talk a little bit about recurrent failure. The things that if things don't work, what can we do? What makes a difference? And I wanted to start this off by a story, a really quite special story that has gained a lot of focus and some TV story over the last couple of months. And it's a story about Mackenzie's mission. And I think I'm going to read out a tiny little bit about the background of Mackenzie's mission. But it's a really nice story also to read for yourself. So, on the 11th of March 2017, my husband Jonathan and I had our first baby. This is straight from the Mackenzie's Mission website. I had a beautiful little, our first baby. We had a beautiful girl called Mackenzie. It was love at first sight. We knew our world had changed forever. Mackenzie was a very planned baby. As a couple, we did all the fertility tests. We did the health checks. We took all the prenatal supplements and did all of the recommended baby health checks, including the non-invasive prenatal tests which screens your baby for chromosomal abnormalities. When Mackenzie was 10 weeks old, our happy, blissful world was ripped away from us when she was diagnosed with spinal muscular atrophy type 1. SMA is a rare neurological disorder characterized by a loss of motor neurons and progressive muscle wasting. In essence, we were told that Mackenzie would slowly lose her ability to swallow and eventually breathe, and would most likely pass away before her first birthday. This was a cruel, devastating disease. SMA is a recessive genetic disorder, meaning both Jenny and I unknowingly carried the disorder in our DNA. It shows up only if a couple who both carry the same recessive genetic disorder have children. That means our chance of having children would be 25% affected by SMA. But SMA is not the only genetic disorder out there. There are thousands of possible lethal disorders. The story goes on. The story is one that you and I have the possibility of carrying a rare, what we call recessive disorder. The commonest ones that you would possibly know about are things like cystic fibrosis. But Mackenzie had spinal muscular atrophy. So people are only affected if both parents carry the gene and both parents have no idea that they carry the gene, as occurs with cystic fibrosis. So Mackenzie's parents went on a mission to make sure everyone knew about the possibility of abnormal genetic disorders. They door-knocked every minister, every politician. And the federal minister, Greg Hunt, said, I think we should put aside $50 million for genetic testing. And as a result, told all general practitioners and told us that it's our role to tell you that there is testing available. So, what testing is available that you can do before you get pregnant to give yourselves a little bit of information with regards to genetic testing? Before I go on any further, I'm apologising. I'm not a great social media buff, and I had everything all ready for questions. I can see the questions are not coming up perfectly for me, but my phone, which is right here, is telling me a little bit about what questions I've got. So, firstly, what are some of the tests, well, what tests do we have available to talk about if we've got genetic abnormalities? Most of the labs today have a genetic test that you have the ability to take, either one or either parent, to test the 4 big chromosomal abnormalities. Well, the big 4 are cystic fibrosis, spinal muscular atrophy, Fragile X syndrome, and a blood disorder called thalassemia. If one parent takes that test, then it's usual that the other parent doesn't take the test, because it's only if both parents have it. So the genetic carrier screen is available both from us at Virtus, and we have a quick turnaround for that, but most other local carriers also have the ability to test that. There are, of course, a whole lot of other genes that are a lot less frequent, and there's the ability to then take an extended carrier screen that may be up to 500 genes tested on the same test. It's both good and bad. It gives us a lot of information, which is what you'll want to know, but because we're all probably carrying one disorder or one abnormal gene, it's usual that both couples would end up taking that test. What type of things are on that test? Now, I've got my cheat sheet as well right here, and they're things, they're much more blood disorders. They're the tests that are done on newborns routinely. They're the tests that run through specific communities, like some specific Jewish communities. So, what are our options before getting pregnant and just checking? Our option is 1, just doing the top 3 and getting our risks. It's called the standard genetic screen. It's a blood test. Or 2, I want the panel with the top 500, but if we end up doing that, it's most likely we're going to have to do both couples. So it gives you lots of information, gives you the ability to say that we can avoid diseases like cystic fibrosis, and it's out there if you wish. The questions I know that are going to be asked, and the first question I can see here is costs. Unfortunately, Medicare doesn't cover the cost of this testing. You certainly would, because you would certainly keep your dockets, because it's a tax deduction at the end of the year, because it's an out-of-pocket medical expense. The blood test for the big 3 costs about $400, and if we want to do the top 500 genes, it possibly costs about $700. If we're wanting to go past that, what else do we do when we're thinking of getting pregnant? Well, I mean, I know you know this because when we're thinking of getting pregnant, it's diet, it's making sure we're on the right dose of folic acid, it's going to general practitioner if we're on any medications, checking that they're the right medications that we can use when we're pregnant. It's making sure we're not on any substances that are going to affect pregnancy or affect the baby as it's developing. This is both with male and female partner, that there are definitely things that affect sperm. So you can really optimize health before wanting to get pregnant naturally. Let's talk about the next step. Let's talk that if we have now a disorder that we all know happens throughout the family, that runs through the family, and I'd like to see if I can change the outcome for my children. Can I decrease the risk of that disorder happening in my children? So that's classic in things like, again, cystic fibrosis. But it's also, we're able to do it where we have a specific disorder that we know, something like the breast cancer genes, the BRCA genes. But we can also do it if we have a rarer disorder that we know comes down the family. What happens is we do something called carrier mapping, where we make up a probe and we can work out where the gene is, and then we can test the embryo. And we can work out which embryos have the disorder and which embryos don't. So the ability to test specific disorders has really changed our life. The ones that have excited me over the last number of months have been the ability to diagnose the embryos with the BRCA gene or the breast cancer gene, with neurofibromatosis, with a number of other specific disorders, and we can change people's lives in the next generation. So that's specific testing. What I'm going to come down to now is a little bit more of recurrent failure, when things don't work. And I can see that's what a lot of the questions are that's coming up. And so I'm getting to those questions. I'm not ignoring them. A lot of the questions are coming about if we have recurrent miscarriage or recurrent failure, or it hasn't worked last time and I want to see if I can increase my chances of this time. So normal IVF, I guess the way I keep thinking about it when we talk about IVF, is mostly just putting egg and sperm together in a dish, pretty much, and letting them do their own thing. So to a large extent, we have the same miscarriage rate, the same chance of chromosomal abnormalities, the same chance of Down syndrome as normally conceived pregnancies. And routinely, I know a lot of people don't understand it and think we do, because they think because we're doing IVF, we're always going to test embryos. But routinely, we don't test embryos. It's the same almost as if it was a natural conception, but just in the lab. So the testing of embryos with regards to recurrent failure, the testing of embryos if I want to improve my success rates a bit, is testing all the chromosomes on an embryo. Now this is very different to I'm testing one gene for cystic fibrosis. I'm testing all of the chromosomes. And we do this relatively commonly if asked. This classically occurs when we grow the embryo through to day 5 or blastocyst, when we take a little biopsy at day 5, and then we test that cell over the next week, and we work out the chromosomes of that embryo. It is a really good way of improving our chances within recurrent embryo failure. A quick little on the side, there's some marketing and play around that we don't have to biopsy the embryo to find out if the chromosomes are normal, and we can test it in the media that the embryos grow in. Now, we're all excited about that. We're thinking that's good for the future, but the evidence isn't there. And the people who are marketing at this at the present time, there isn't peer-reviewed evidence that we can give you. And so the gold standard still for testing embryos is an embryo biopsy at day 5. I want to look for just a question, or look for a second or so at a number of the questions to see if I'm can answer before I go on to the next step. Firstly, what are the type of tests we do if we're having trouble conceiving naturally? Not quite the scope of what we're going into here today, but I really think conception is pretty simple, mostly. It's, are we ovulating? So we look at tests for ovulation. Is the sperm okay? And are the tubes open? So the normal tests that we would often do right at the very start are simple things. A blood test called AMH to see how many eggs we've got. A simple semen analysis. And that gives us a lot of answers right at the very start. When should couples consider egg or embryo donation if they've had multiple IVF failures? Well, I mean, that's a really heartbreaking question. It goes to the very root of what we do. I want to tell you a story. So at Queensland Fertility Group, we have a session where all the doctors in Queensland Zoom in, and we present our difficult patients, our patients who, for all reasons, we think should be getting pregnant and aren't. And you get feedback from all of our peers and all of our colleagues. And at the end of that, there is sometimes where you get everyone saying, gee, you've done everything. And the scientists saying, every time we see it in the lab, it's not working. And yeah, in that scenario, I really think it is my role to say, look, I think it's really difficult. And although I'm never saying it's not going to happen, but your best chances are donor egg or donor embryo. But it's an individual discussion. It's an individual review of individual cases. It's never something that's taken lightly. And it usually is something that I want to get feedback from our scientists and other colleagues when we talk about that. What type of tests with regards... I'll come back to recurrent losses just for a minute. We are going to talk about what type of tests are available also once we are pregnant. And the standard test that everyone has, or most people have today, or the gold standard test, is called NIPT testing, or non-invasive prenatal testing, where we get fetal cells in the maternal circulation. Today, that's mostly checking for Down syndrome, 3 chromosome 21s, 3 chromosome 18s, 3 chromosome 13s, and sex chromosome abnormalities. But more and more we're seeing this space explode with the possibility of testing for other abnormalities once we are pregnant. If today I'm looking for very specific things when we are pregnant and we haven't tested for it before with IVF, we still have the ability to do amniocentesis, where we take some cells from around the baby, the fluid around the baby, and we can test those cells for diagnosis in the same way as we test embryos. So yes, we can still test when you are pregnant. It's just that in a lot of people's vision, it's probably more optimal to do it before we're pregnant. How much does genetic testing cost? Um, Splitting them apart, the pre-genetic testing, which is before we even get pregnant, so everyone, not even just fertility people. So we talked about the simple 3-gene test, which was $400, and then the bigger test, which was $700. The testing of embryos themselves, including the biopsy and then testing afterwards, I'm hassled about giving an exact number now because I was just having a mental blank, but my memory is approximately $700 an embryo, up to a maximum, I think, of 4 embryos, and if we're testing more than 4 embryos, it's a maximum of about $2,800. It sounds a lot of money, but with IVF can often be a very cost-effective thing with doing that. What tests are most beneficial for people of Caribbean descent? Now, there's no specific disorders I know of that are specific with Caribbean. There's a lot of racial groups that do have specific disorders. There's a number of Asian countries that have some blood disorders. The Mediterranean countries that have blood disorders. But from a Caribbean descent, I think we just look at the normal genes that we were all just talking about before. We're talking about multiple implantation failures or recurrent implantation failures. And so coming to that specific topic, which I can see there's a whole lot of questions about. And there's questions because it's a really difficult, hard area where in the end, mostly we are not giving you a black and white answer. So we're looking at, firstly, are we due to chromosomal problems? And that's the reason for talking about pre-implantation diagnosis. We then are talking about, is there any structural reasons that the embryo has difficulty implanting? The area where the embryo wants to implant, called the endometrium, is there scarring? Is it too thin? So we can investigate that specifically by ultrasound, by hysteroscopy where we have a look inside. Is there any area surrounding within the pelvis that makes it a more toxic zone for embryos? We know, for instance, that things like endometriosis decrease our success over medium time. But once we've excluded those things, then it gets harder because we're starting to think about immune factors. We're talking a lot about immune factors recently because of viruses and how our body reacts to immune. But the immune factors surrounding decreasing the ability to an embryo to implant, we know, we understand that it's there. We understand immunity is a very big part of how something that's a little bit foreign, because it contains part of the male chromosomes, something that's a little bit foreign implanting into your uterus, must have some type of immune impact. But our tests aren't spectacular for this. And a lot of us talk about the different ways of managing immune factors, with different ways of flushing the uterus, with different ways of being able to use immune suppressant medications like steroids. But what I think is very important is that we're giving you absolute evidence base. We're not just throwing everything at you to make a to see how we go. We're looking for reasons and giving you evidence base as to how to treat that. Another grey zone that we understand is associated with recurrent implantation is as the embryo is trying to implant, if there is any coagulation or blood clotting disorder, does that make it difficult for the embryo to implant? And so investigation of that. So it's a really hard area, but the main factors in summary again are structural reasons of the uterus, fibroids, polyps, uterine abnormalities, uterine scarring, structural reasons with the endometrium where the embryo wants to implant. Has it been scarred? Something called Asherman syndrome. The possibility of endometriosis on the outside. The possibility and even probability of immune factors surrounding it. And the possibility of blood coagulation factors and manipulating that. Going back to looking at questions for a sec. There's definitely a lot of talk about stress and work and that process. And I'm totally with you. And the reason is because you hear it as a story, but you see it so many times when you're working in fertility that it's really, really difficult to get pregnant the first time. You do IVF, you do all the things, and then all of a sudden we get pregnant the second time without too much difficulty. And the only difference usually in that area is stress. And so I accept that I'm not belittling that in any way, but it's a really difficult thing for me to treat. I just can't say, oh, don't be stressed and get pregnant. So yes, I think those things are part of it and we should recognize it, but we should optimize all of your management. There is discussions on here about grading of embryos, what advice do we give to putting an embryo back in, and how can we say how good the embryo is. I guess my first thought and comment is that if an embryo is still growing at day 5 at blastocyst and still continuing on, then there's always a chance of it working. After that, we've traditionally graded the embryo on a whole lot of different ways without heaps of evidence. What's been really exciting in our sphere over the last year or so is the development of artificial technology that a camera looks at the embryo and keeps taking photographs, and at the end of watching the embryo every few minutes for 5 days gives you via artificial intelligence a possible and predictive score of which embryos we think are the best. Deliberately within QFG, we know it's being developed. Deliberately, we are waiting for it to be fully peer reviewed before releasing it and before talking about it. And so I don't absolutely talk to my patients about what their IV or artificial intelligence score was, but I'm also always interested in the background looking at it. So there's a lot of ways of grading embryos, but I think that into the future we're going to have much more scientific ways of grading embryos, and I'm very excited about our ability to do that in the not too distant future. Miscarriage is, it's horrible. We've gone to all this, everything. We got excited. We found the ups and downs of IVF. We've had a failed pregnancy. When to do the next transfer, which is one of the questions or next questions. There is no medical reason, usually, not to go straight away the very next month. In fact, medically, there's probably a slight advantage to going straight away the next month. But as a person, you're more than a number, you're more than a medical. It's the psychology, it's the really difficult time we've had after last month. So my normal answer to when to do the next transfer after miscarriage is all else being equal, including very, very importantly, mental health. no reason not to do things the next month. There's a question with regards to diet and supplementations with regards to optimal embryo implant. And at this point, I would differentiate between a cycle where we make an embryo and put the embryo back in at the same time, and in that cycle, the vitamins, there are vitamins with regard to the antioxidants still for egg quality. We're keeping our folic acid up for embryo development is really important. But we differentiate that between the exact question is for an optimal embryo implant. So if we've had a frozen embryo and it's been frozen for a while, the only things we would routinely think of vitamin supplementation for embryo transfer only without making the embryo is probably still just folic acid for embryo development. I promise, because I was only wanting to go on for approximately half an hour so that you weren't totally bored. I've got about 2 more questions that I can see, and then I thought I would summarize a few things, and thank you very much for a night. So, in view of a couple more questions, just to give you, is diminished ovarian reserve a risk factor for recurrent IVF failure? Probably not. In very, very, very low ovarian reserve, we are now starting to understand that it is also probably associated with poorer egg quality, and poorer egg quality probably is associated with decreased success as well. But this is very low. In just, ovarian reserve is on the lower side. That in itself is not usually associated with recurrent failure. There was a question with regards to when do we test embryos if we are testing them. The only reason we used to look at testing embryos at day 3, but that is almost never done now. It almost entirely is done as a day 5 or blastocyst, because this is the time. Day 3 is 8 to 12 cells, where blastocyst on day 5 is there are so many cells because the cells are trying to break out of the shell and trying to implant in the uterus, and taking cells when they're breaking out anyway really has no effect on embryos. So with that, what I really wanted to talk about tonight was, firstly, make sure that people were aware, if they wanted to, the ability to test for genetic disorders before even trying to get pregnant, that those tests are out there, and that general practitioners, gynecologists are being helped or told by governments to make sure you know all about it, and I think that's a great option. Secondly, we do have the ability to test embryos before re-implanting them, and we either do that for specific disorders and making sure we can diagnose those beforehand. The classic things are things like breast cancer gene, things like cystic fibrosis. Thirdly, we have the ability just to test embryos to see if they are chromosomally essentially normal, and therefore increase our chance of success. And this is especially the case with things like recurrent failure. And fourthly, the really difficult topic of recurrent failure, because there isn't a perfect answer, is go through things, make sure there is no obvious causes, and then talk about the pros and cons of testing embryo the way we treat immunologically, and the way we treat if we think there's a blood clotting disorder. I'd like to thank you all very, very much for listening to me tonight. I know there's so much else you could do. I hope if the reason you were tuning in is to get a little bit of clarity on where you are, I hope you've got that. I wish you the very best of luck for your future fertility endeavours, and thank you, and I hope you had a good night. Thank you.